Welcome back to the Ask Me Anything with Dr. Twyman. Going to help you guys become heart attack proof if you're not already. So, I have some great questions tonight, ready to answer them and rock and roll. First question up tonight: can modified citrus pectin support a cardiovascular health? Possible, not one that I've seen many patients use. It may have some effect at lowering LDL cholesterol, but more important to focus on using things that have outcome data. Citrus pectin, I haven't seen it. Nothing harmful for it, but don't think it has a lot of benefits. High ApoB, LDL in particles, but not insulin resistant. CRP is low. Calcium score 7. Low blood pressure, 54 years old. So don't know what the question exactly is, like what is next steps, but I usually break it down to, do you have optimal endothelial function? So you can test nitric oxide with salivary nitric oxide test strips. You can look at arterial elasticity. You can look at endopat scans. Then you can look at a CIMT to see, do you have vascular inflammation in your carotid? Because the calcium score test just tells you that you have old plaque in your arteries. Doesn't tell you, do you have ongoing plaque buildup? And then ApoB is part of the equation. If you have a calcium score above 0, you likely should shoot for the 20th percentile on ApoB, and that is a value generally under 70. You can use Boston Heart Test to determine, is it more of a hyperproduction issue or a hyperabsorption issue? That can guide if, statins are better options, ezetimide's a better option, or if there's something lifestyle related that you can do. But if you're not insulin resistant, rarely is it going to be a nutritional change that makes any difference in the type of proteins, because the majority of the cholesterol metrics are driven by genetics. Are there any benefits to capsaicin? I think I got this question the other week. Mainly I've seen it for musculoskeletal pain, but there may be some slight benefit for endothelial health and preventing oxidative stress, but I don't think that the data is that compelling. And I think it's a continuation question, is capsaicin cardiovascular health and possible plaque buildup? No, I've not seen any data that it has any benefit for plaque regression. Again, it's maybe more anti-inflammatory, and it may have some effect on endothelial function. What water or water system can a city dweller use? Depending on what part of the country you live in, is, what is being added to your municipal water. The big concern is always going to be fluoride, irrespective of what fluoride might do for your teeth. It is a neurotoxin, disrupts the oral microbiome, can affect the thyroid. So you generally want to avoid drinking fluorinated water. So reverse osmosis filters can strip out fluoride. The Berkey filters can. There's some other companies that have filters that report to do that, but you need a very good filter. The traditional tabletop filters from the grocery store or your big box stores aren't going to be able to do that. Personally, I like spring water, so I get spring water delivered in glass bottles to my house. "41-year-old man, great labs except LDL 142, ApoB, and total, possible FH, next steps." So great labs is depends on what you're looking for. When I'm checking labs for my patients at Apollo Cardiology, I'm looking at over 200, 300 metrics. Very rarely do people have perfect labs, everything green. I honestly don't think I've seen anybody have all green labs on their testing. Now, there are themes. Are there things that are affecting your nitric oxide pathways, like high uric acid, high homocysteine, high ADMA? Are there elevated oxidative stress and inflammatory markers like elevated GGT, oxidized LDL, OXPL, ApoB, high sensitivity CRP, high plaque test? And then you look at the lipoproteins. So if your LDL cholesterol is 142 and total is 212, that is not familial hyperlipidemia. You need an LDL cholesterol over 190 and a total cholesterol over 300. So not likely familial hyperlipidemia, but you may have a polygenic cause for your elevated lipids. Most of the time that's the case, where you have multiple genes combining to give you that pattern. So next step is looking to see, do you actually have plaque in your arteries? So a calcium score and CIMT scan is a good start. But if you want to know what genes are affecting it, typically looking at GB insight panels tells you what genes exactly is causing the lipid abnormalities. 44-year-old female with a high sensitivity CRP of 4.9, so normal is less than 1, and an ApoB of 130, which is well above the 90th percentile, meaning 90% of the world would have values lower. Person's eating an anti-inflammatory diet and takes arterosil, which is a glycocalyx promoter. What else? Again, start with, do you have actual plaque in the arteries? That determines how aggressive to be with the lipids and the inflammatory markers. The lipids, multiple agents can be utilized if needed. So if it's not due to insulin resistance or eating a keto diet, generally dietary interventions won't have a significant effect. So would focus on what is causing the high sensitivity CRP to be elevated. Is it chronic infection? Is it an autoimmune condition? And treating that directly. And then for the lipids, you can use the Boston Heart Diagnostic Panel to figure out, is this a hyperproduction issue or hyperabsorption issue? But when the ApoB is 130, there's often going to be a large genetic predisposition. And depending on your risk tolerance and your hopeful longevity, being 40, 50 years, you probably want to consider doing something, and they'll likely end up being pharmaceutical in nature at some point to lower the lipoproteins. What test to measure soft plaque in the arteries? The carotid intimedial thickness scan can see it, but the main one would be that we utilize at Apollo Cardiology is the Clearly CT coronary angiogram. It uses AI to assess the plaque in the walls of the artery. It can tell you the total plaque volume. So soft plaque is the plaque that you're trying to treat. Hard plaque is a scar. The goal is to get the soft plaque to delipidate, shrink, or get the soft plaque to turn into hard calcified plaque. The goal is you don't want the soft plaque to become low density plaque. That low density plaque is necrotic and inflamed, and the plaque that's more likely to rupture. What test for hard plaque? The CIMT can also see mixed plaques and calcifications in plaques. But the plain old CT coronary calcium score test, which is about $100 to $150 US, can see hard calcified plaques in the coronary arteries, but they clearly can quantify how much hard plaque is present as well. Next question, does cutting out sugar and carbohydrates for a year help reduce plaque in the arteries? I would say possible, but I always start with, sugar is a fuel source. Sugar isn't good or bad. There's a dose response. If you have very healthy mitochondria, you have a lot of skeletal muscle, you can eat more carbohydrates. If you have low muscle mass, you're sarcopenic, you're probably going to be able to eat less. Most people should try to probably not push more than 40 grams of carbs at a meal unless they're doing a lot of activity after the meal. So it's more about your insulin response than it necessarily is just your sugar. So could it help? Possibly, but it depends on where you're insulin resistant to start with. If you reverse insulin resistance, that potentially does help with the glycocalyx regenerating, and then the body can get to work at trying to stabilize and potentially reduce plaque in the arteries. Patient says, I'm concerned about long-term use of aspirin. Should I be? It's a good question. It always depends on, is this for primary or secondary prevention? If it's secondary prevention, meaning you've already had a heart attack, stroke, stents, or bypass, your risk of having another event is not trivial, and aspirin can lower that risk and should be offered, unless the person's allergic to aspirin or has a high risk of mostly gastrointestinal bleeding. For primary prevention, which honestly is rare, at least in my practice, because if you do the right testing, you generally will find some degree of plaque in most individuals over the age of 40. And then it comes down to how much plaque is present. If they have a calcium score over 300, even though they've never had a heart attack, their risk is equivalent to they've already had a heart attack, and they should at least be offered aspirin. It's not something I think everybody needs for prevention, but if you have plaque in the arteries, it's something you should consider. So those are the pre-submitted questions tonight. Thank you. Those are always going to be the first ones that we answer on this IG Live. Every Monday morning, I put the questionnaire box up in my story and answer them as they come. But we always have more time for questions, so I see that there's some in the comments, so I'll answer them as well. So, can I comment on all the discounting of high LDL cholesterol and ApoB versus insulin resistance by the Feldman and Norwitz crew? Norwitz, I think, has a 300 to 400 LDL cholesterol. This is something that I discuss on numerous podcasts and with patients that fly in to come see me who have these kind of lipid profiles. I've definitely seen patients have this pattern where their lipids, significantly increase when they're on a extended low carb type of diet. So usually tell them that I care more about what the arteries are doing than I care what's in your blood. So we look to see, do they have endothelial dysfunction? Do they have plaque in their carotid or coronary arteries? And if so, offer them treatment. So I understand why some people pick this type of diet. It helps with their gut health in some individuals. I think that's what Norwitz did for. Some people do it for brain health. But if you're not able to switch off of that diet for whatever reason, then consider using, standard lipid lowering therapies. But generally, having a LDL cholesterol 3,400, is going to require multiple interventions if you're interested in lowering that number. I understand why they don't think it's a big deal short term, but the data is relatively clear that long term, the more lipoproteins you have, the more shots on goal there are, the more chances you're going to develop atherosclerosis. Not guaranteed. If you have a healthy glycocalyx and a robust immune response that stays down, you may not develop significant plaque with it. But think of LDL cholesterol as potential energy, potential plaque. The more you have, the more chances you're going to lay down plaque with it. Not in all instances. So, what I learned from a lot of mentors is test, don't guess. So, I've seen many patients with this type of pattern. Nothing at this stage of my career really scares me. It's all about just risk management and what is the patient more comfortable with, having high lipids, taking medications, or changing the diet. Somebody says that they don't have insulin resistance and normal homocysteine. So insulin resistance is one of the worst things for the glycocalyx. Homocysteine, when it's elevated, can increase a compound called asymmetric dimethylarginine, or ADMA. High ADMA is associated with lower nitric oxide, and lower nitric oxide is associated with endothelial dysfunction. So if the lining of the arteries, the endothelium is dysfunctional, the person's more prone to developing plaque in their arteries. Okay. So I don't see any other questions popping up at the moment. If any pop up, I'll happy to answer them. While we're waiting for that, just a reminder, I still work with patients one-on-one at my practice in St. Louis, Apollo Cardiology. If you're not currently my patient and you're interested in getting some of these advanced imaging testing, advanced genetic testing, or the advanced lipid testing, we have availability in my practice. I am booking out, I believe, into April or May at this time. So if you're interested, go to my website, drtwyman.com, click on the application, and a member of my team will contact you to discuss what your concerns are and discuss the logistics of working with our practice. Second housekeeping is that I will be having a school community Ask Me Anything this Friday at 1 p.m. Central Time. The school community is where I post my more long-form content. I'm using AI to create some infographics, answering more detailed questions there. And Ask Me Anything is live where we use their platform and I can see you, you can see me, and we can kind of go back and forth on some of these questions. So there's a free 7-day trial if people are interested. The website is drwyman.com/school, or if you go to school.com/drwyman, you'll get to the group. The group is becoming heart attack proof. And I see two other questions popping up. We'll try and answer. Is it possible to lower or reduce high lipoprotein naturally? The short answer is no. If you have significant inflammation, if you can figure out what the root cause of the inflammation is, I have seen LPA decrease. With LPA, everybody creates it, but approximately 20% of the population has high values. Value over 900 would be very high, likely have multiple LPA genes. The GB Insight panel looks at the different LPA genes. The patients who have more of the short isoforms will generally have these higher LPA levels. Those are the patients that, are at increased risk of vascular disease, the more LPA you have. There are a couple of labs that I've always checked with patients with LPA, and those include the LP-PLA2 activity, that's an inflammatory enzyme, OXPLA-ApoB, which is a phospholipid that gets damaged, and then interleukin-6. If those three labs are elevated, then LPA is potentially actively inflaming and damaging the arteries. Currently, the PCSK9 inhibitors are the only treatments that really have any effect at pushing the LPA down. Hormone replacement therapy in some women will have an effect, but not a significant reduction. And then the apheresis is really the only approved treatment to significantly lower LPA. The drugs, the antisense oligonucleotides, they're still at least a year away before hitting the market. Question, how do I feel about taking supplemental nidokinase to help support a cardiovascular health? This is a question I'm getting more often. There's a study out of China, was not a randomized trial, wasn't placebo-controlled, it was an observational trial, and they were using high-dose natto versus low-dose natto, and the take-home was that the people with higher dose natto may have had their plaque improving, but wasn't blinded, would like to see it repeated, and the question is, what is the mechanism other than lowering fibrin? Don't know really what the long-term benefit would be if you did not have high fibrinogen on lab work for people to take natto. Not opposed to it, but it doesn't replace aspirin, and if you're on any type of anticoagulation or blood thinners, you gotta talk to your doctor before considering nattokinase because it does thin the blood. Well, great questions as always, guys. I always appreciate your time and attention. Answering these questions always tries to keep me sharp and helps me when I chat with my patients and when I go on these different podcasts, I get asked similar questions. So this is always kind of like my batting practice, those questions I get asked. So I'm always here every Monday, 6 p.m. Central Time to answer them for you. And if you're looking for more details about, might ask me any things where I can go more in depth in your story, I've got my school community. So hope you guys have a great evening and we'll see you next time.